Treatment goals for GERD are to eliminate the symptoms, heal esophagitis, manage or prevent complications, and also to maintain remission. Next slide. The first and foremost treatment for GERD is lifestyle modification. Next one, we can go for a control of gastric acid secretion by medication. And third one is restoring the anti-reflux mechanism, which is purely a surgical modality. Lifestyle modification, every patient who is coming from GERD, we must advise the patient for a head and elevation, then avoidance of tight-fitting clothes, weight loss, restriction of alcohol and smoking, dietary changes, that is to avoid very spicy food, citrus fruits, and also having a minimal exercise daily, which will help. Around 20 to 30% of the patient will be symptomatically better after a lifestyle modification. Next slide. Pharmacological treatment, first we'll start with the antacids. Even though they are not very effective, but patient can have a mild symptomatic relief, which should be taken after each meal and at bedtime. Next slide. Prokinetic drugs are the second one, which increases the acetylcholine release in the mandate plexus, which improve reflux symptoms by increasing LDH pressure and also causing gastric empty. Next slide. H2 blockers like ranitidine, famotidine, and nizatidine are the more effective. They are more commonly used in controlling the nocturnal acid breakthrough as compared with the meal-related secretion. The 4-H receptor antagonists are usually effective when used in proper doses. That means usually twice a daily usage is needed. Grade 1 and grade 2 esophagitis will have a 60 to 90% of healing, but higher grades like grade C or grade D esophagitis are not much responsive to H2 receptor antagonist. Next slide. PPIs are the main treatment modality for GERD. It inhibits meal-stimulated and nocturnal acid secretion to a significantly higher degree than H2 receptor antagonist. After oral ingestion, acid inhibition is delayed because it needs to accumulate in the parietal cell secretory canaliculus. Therefore, as lower PPI is cleared from the plasma, the more it is available for delivery. PPI should be taken before the first meal of the day. Next slide. PPIs, omeprazole, lansoprazole, rabeprazole, pantoprazole, and esomeprazole have superior efficacy compared to H2 receptor antagonist. PPIs are superior to H2 receptor antagonist in completely relieving heartburn symptoms in patients with a severe GERD. As I told earlier, grade C and D will respond only to PPIs, whereas A and B esophagitis can have some symptomatic relief with the H2 receptor antagonist. Next slide. So this is a treatment algorithm. You can initiate with the H2 receptor blockers or PPI once daily dose. If there is good response, we can maintain the patient with the lowest effective dose. If the patient is not having any symptomatic benefit, we can increase the dose to twice daily dosage and maintain the therapy. Next slide. So with lifestyle modification, there is 20% response, H2 receptor 50%, single dose PPI 80%, and double dose PPI, patient can have a 100% response. Next slide. So whenever the patient is not responding to medical therapy, the next modality available is surgical treatment. But 80% of patient with a GERD will have a non-progressive form which can be controlled by medications. Only 20% will progress. They will develop some form of complications such as a stricture, a Barrett's. So in those patients only, we have to go for a surgical treatment. Next slide. Anti-reflux surgery primarily indicated to reduce gastroesophageal reflux by increasing the basal pressure, decreasing the episodes of transient lower esophageal sphincter relaxation, and also inhibiting complete lower esophageal sphincter relaxation. Next slide. So what are the indication? Anti-reflux surgery is indicated or it is reasonable option in a healthy patient with a typical or atypical GERD symptoms, well controlled with the PPI, but they are desiring an alternate option because they want to avoid drug therapy. Or in a patient with the volume regurgitation aspiration, or there is any very severe symptoms or complication, that patient can go for a surgery. Next slide. So what all we have to do before going for surgery? Anyway, we should have an endoscopy to rule out complication like stricture, Barrett's, dysplasia. A barium esophagogram will be helpful. Esophageal manometry should be combined with an impedance to rule out presence of an achalasia or scleroderma. And 24-hour pH testing is necessary because only this test can confirm the presence of GERD before going for an anti-reflux surgery. Next slide. Gastric analysis and gastric emptying studies, they are add-on to other routine tests. Next slide. Anti-reflux surgery relieves reflux symptoms and reduces the need for stricter dilatation more than 90%. But Barrett esophagus rarely regresses and risk of developing esophageal carcinoma is unchanged even after an anti-reflux surgery. Next slide. So these are the most common operation used before laparoscopy: Nison's fundoplication, Belsey's mark for repair, etc. Next slide. And after laparoscopic era, now we are using laparoscopic Nissen fundoplication, which is a 360-degree wrap around the stomach, a wrap of the stomach around the esophagus. And Toupet fundoplication is an incomplete, that is 270-degree wrap of stomach around the esophagus. Next slide. So these are the total fundoplication, that is Nissen, and Toupet fundoplication, which is a 270-degree. A small portion is left without a stomach wrap. Next slide. So it is a very common surgery. Hospital stays only 1 to 2 days, and many patients can remain active after 7 to 10 days. Next slide. There are small complications which are there, like 10% patient can have a solid food dysphagia because of a tight wrap, and 3% can still have reflux symptoms, and others can have a gas, bloating, diarrhea, etc. Next slide. Now, newer endoscopic treatments are coming into light, which are relatively new and which will give you a more anti-reflux effect without undergoing a laparoscopic surgery. Next slide. So endoscopic GERD therapy include a strata procedure, which is radiofrequency energy delivered to the LES to increase the LES reflex barrier. And another one is endoscopic plication. And another one is submucosal implantation of inert material in the region of lower esophageal sphincter.